Hello friends, today we are going to discuss the hepatic encephalopathy. Hepatic encephalopathy is broadly defined as the brain dysfunction caused by liver insufficiency and portal systemic shunting, which manifests as wide spectrum of neurological or psychiatric abnormalities ranging from subclinical alteration to the coma. So hepatic encephalopathy is the complex pathophysiology that remains incompletely understood. Ammonia has been historically known to be a major contribution in hepatic encephalopathy development. Gut bacteria have a major role in the production of ammonia from urea, that is the product of the dietary protein digestion. So normal liver converts the ammonia to urea that will be excreted by the kidneys. So skeletal muscle also plays a role in the clearance of ammonia from circulation via amidation of glutamate to the glutamate. However, in patients with cirrhosis and portal hypertension, ammonia cannot be metabolized by the liver and is shunted to the systemic circulation and eventually enters the body by crossing blood-brain barrier. A chronic liver disease causes the other systemic effects such as portosystemic shunting, microbiota dysbiosis, malnutrition, sarcopenia, electrolyte imbalance, gastrointestinal bleeding that results in the worsening of hyperammonemia and systemic inflammation and oxidative stress, and increase blood ma- manganese, bile acids, and lactate. Consequently, these pathogenic factors lead to the disruption of the blood-brain barrier and increased influx of molecules such as ammonia that normally do not cross the blood-brain barrier. So, after entrance of ammonia into astrocytes, that is the cell which are present into the brain, it combines with the glutamate to form glutamine, which trigger the formation of reactive oxygen species, swelling of astrocytes, which in turn results in the neuronal dysfunction and hepatic encephalopathy manifestation. The ammonia also causes the mitochondrial dysfunction, disruption of cellular bioenergetics, effect on the brain. It also plays a role in the neuronal depolarization and asterexis by causing increase in neuronal resting membrane potential and inhibition of the outward chloride pump, leading into the inhibitory postsynaptic potential formation suppression. In addition to the ammonia production, the colonic bacteria plays a significant role in hepatic encephalopathy development through other mechanisms. Advanced cirrhosis is associated with decreased bile acid production, disrupted enterohepatic circulation, and conversion of primary to secondary bile acid that results in microbiota dysbiosis. Use of proton pump inhibitors in patients with cirrhosis due to various indications also result in decreased gastric acid secretion that promote hepatic encephalopathy development through intestinal bacterial overgrowth and translocation. Several precipitating factors have been reported for hepatic encephalopathy development, including infection, electrolyte imbalance, dehydration, constipation, and gastrointestinal bleeding. Addressing this factor is the cornerstone of hepatic encephalopathy management. The heart of this semi-quantitative nature of the West Haven criteria, which have not defined grade 1 hepatic encephalopathy well. So we have simplified this grade 1 hepatic encephalopathy by calling it as covert because of its sound, which is opposite to the overt. Therefore, in patient with a deranged psychometric and neurological test, but no grade 2 hepatic encephalopathy, the umbrella term covert was introduced. So covert hepatic encephalopathy requires the testing for its detection and quantification, and diagnosis cannot be made clinically, and its validity has been determined using standardized patient testing modality. However, it has been shown that covert hepatic encephalopathy is heterogeneous entity and that grade 1 hepatic encephalopathy abnormalities have additional prognostic and possibly also therapeutic implications compared to abnormalities on testing for hepatic encephalopathy alone. So this is the classification uh, uh, which uh, which will tell us about the grades of hepatic encephalopathy according to the West Haven and ISHN criteria. ISHN is International Society for Hepatic Encephalopathy and Nitrogen Metabolism. So according to this, grade 0 and grade 1 falls into cohort. Grade 2, grade 3, grade 4 falls into the overt. So grade 0 is no clinical evidence of change in personality or behavior, minimal psychomotor and the neuropsychological alterations detectable only via psychometric and neuropsychological test. Grade 1 is slight lack of awareness, decreased attention span, impaired addition and subtraction, euphoria, anxiety, and altered sleep pattern. Then overt includes grade 2, grade 3, grade 4. Grade 2 includes lethargy or apathy, disorientation, obvious changes in personality, and inappropriate behavior. Grade 3 includes somnolence, semi-stupor but responsive to stimuli, notable confusion, disorientation, and strange behavior. Grade 4 is the coma, which is unresponsive to painful stimuli. Now we'll see how neuroimaging study will help us in diagnosis. So diverse neurological manifestation of chronic liver disease presents the diagnostic challenge for modern hepatologists with the magnetic resonance technique presenting a highly profitable avenue to investigate structural and functional aspect of brain dysfunction in an objective way. While there is widespread acceptance of its importance, there is little consequences on how best to diagnose and monitor hepatic encephalopathy. So there are several studies are available. So first one is volumetric T1 weighted MR imaging, which will tell us about regional and global change in brain size. Reduction in the brain volume is observed in patients with hepatic encephalopathy. Then the next is magnetization transfer MR imaging. It measures the shift in the bound and the free water content, which have been associated with intracellular and extracellular edema and alteration in the same membrane fluidity. In patients with hepatic encephalopathy, there is evidence of reduced magnetization transfer, indicating increased brain water. Then diffusion weighted MR imaging, which measures the ADC of the water molecule associated with structural damage to the water white matter tract. Changes in the ADC have been observed in patients with hepatic encephalopathy. Then the next is functional MR imaging. It measures the change in the blood flow in metabolic active area of the brain related to oxygenation and the deoxygenation of the hemoglobin. Resting state or response to the cognitive task can be assessed in imaging paradigm. In patients with hepatic encephalopathy, changes in the functional MR imaging have been shown to occur. Then the next is MR spectroscopy. This it is again divided into P and PMR spectroscopy and HMR spectroscopy. So PMR spectroscopy measures the energy metabolites such as ATP, phosphocreatinine together with cell membrane precursor, cell membrane degradation product. So widespread changes in the P metabolite have been shown to occur in patients with hepatic encephalopathy. Then HMR spectroscopy measures lactate, choline, glutamine, glutamate level, and fluxes in the osmolytes such as myoinositol and tau. So neuronal integrity reflected by N-acetyl aspartate measure. It cannot measure ammonia level directly, but increased glutamine represents amidation by glutamine synthesis. This is best validated imaging test that may be useful for diagnosis of hepatic encephalopathy, as severity of hepatic encephalopathy is shown to correlate with changes in the metabolism. Then the last is PET scan. So depending upon the radioligand used, the information can be obtained on wide variety of the brain activity, including neurotransmitter binding, then TSPO activity, and glucose utilization. So several studies using PET have the revealed alteration in the blood flow, perfusion, glucose utilization, oxygen, ammonia metabolism, benzodiazepine receptor expression, and neuroinflammation. So, so now we'll see what are the therapeutic modalities. So therapeutic targets for hepatic encephalopathy. So it mainly concentrated on the lowering ammonia level. So the production of the ammonia is mainly happen into the gut. So many therapeutics target the gut to reduce the production and absorption of ammonia, including rifaximin, lactulose, probiotic, activated carbon microspheres, then engineered bacteria and fecal matter transplantation. Alternatively, ammonia clearance can be targeted via the residual hepatocytes and muscles with L-ornithine and L-aspartate, ornithine phenyl acetate, branch chain amino acid uh, benefit the muscle in clearing ammonia. The binding property of the albumin remove the toxic molecule in circulation via infusion or with extracorporeal albumin dialysis. Liposome supported peritoneal dialysis of the glutamine synthetase replacement can also benefit in the eliminating ammonia. GABA receptor modulating steroid antagonists are centrally active. So, management of the overt hepatic encephalopathy. As mentioned, the diagnosis of hepatic encephalopathy is challenging, particularly in cohort or minimal groups. So the diagnosis of the overt is relatively straightforward and is usually diagnosis of exclusion. In complex situation, particularly when there are no obvious precipitating event leading to hepatic encephalopathy, diagnosis may be more difficult. In alcoholics, it may be difficult to distinguish hepatic encephalopathy from withdrawal. So cross-sectional imaging of the brain should be performed in patients in whom diagnosis is not clear and is usually necessary in patients that presents with the localization. A step 2 approach to differential diagnosis has been suggested. Uh, Response to treatment may be the powerful tool for diagnosis and differential diagnosis. A disease that responds to ammonia lowering treatment is likely to be H. Thus, when syndrome is mild and diagnostic tools are limited, treatment may help confirm the diagnosis. However, the time needed to decipher whether the patient respond to treatment or not is critical time, and episode lasting longer than 48 hours lead to high mortality. Now, role of ammonia measurement. The EASL, AASLD guidelines, that is European and the American guidelines, are not clear on the role of ammonia measurement in the hepatic encephalopathy. So in patients suspected of overt hepatic encephalopathy, normal ammonia concentration can be used to rule out diagnosis of hepatic encephalopathy because negative predictive value of normal ammonia concentrations is high. The best evidence from prognostic role of ammonia and its relationship with severity of hepatic encephalopathy is observed in patients with ALS. It is clear that the ammonia level of more than 120 mmol per liter seems to identify a group of patients at a risk of developing intracranial hypertension and cerebral edema. In patients with cirrhosis, recent data have demonstrated the important prognostic role of elevated blood ammonia. Although the level of Ammonia does not follow the severity of hepatic encephalopathy. More severe hepatic encephalopathy is associated with higher ammonia levels. It is interesting to note that advanced stages of hepatic encephalopathy are associated with relatively low ammonia level in cirrhosis compared to ALF, suggesting other factors in addition to ammonia may be pathologically important in cirrhosis-induced hepatic encephalopathy. In any case, elevated ammonia level have been shown to be associated with reduced transplant-free survival in acutely decompensated cirrhosis. Importantly, a response to intervention that is associated with reduction in ammonia concentration is associated with good outcome, and the reverse is true if an ammonia increases further. This observation is supported by studies of various interventions such as lactulose, rifaximin, extracorporeal albumin dialysis, where reduction in ammonia was indeed associated with improvement in the severity of hepatic encephalopathy. In a prospective study, ammonia cutoff of 80 was shown to be associated with high risk of death, irrespective of severity of hepatic encephalopathy. This suggests that ammonia is more than just neurotoxin and can serve as biomarker of outcome in patients with cirrhosis and acute decompensation. Therefore, increasing evidence that ammonia can exert its toxic effect on extracerebral organ and tissue strongly support its management, not only to reduce hepatic encephalopathy, but also to prevent multiple organ injury and mortality. Now, the treatment of an episode of overt hepatic encephalopathy. Now, general measure. The main aims of treatment are managing bouts of overt hepatic encephalopathy efficiently, reducing its duration, limiting its consequences, preventing recurrence and hospital admission, limiting effect on patients' quality of life, social and professional functioning, and limiting its impact on the patient's family and care. Now, the treatment of an episode of overt hepatic encephalopathy in patients with CLD include initiation of care of altered consciousness, which includes securing airway, hemodynamic stabilization, and ensuring the patient's safety to prevent physical injury. Patients with hepatic encephalopathy 3 or higher or Glasgow coma score less than 8 should be intubated in order to prevent aspiration. But this is not possible in many hospitals, and in this environment careful attention to airway protection and close monitoring should be instituted. Evaluation of alternative cause of altered mental status, including CT scan of the head for first time presentation of hepatic encephalopathy, or if there is a history of seizure, headache, fall, and neurological evaluation, reveal focal deficit. Identification and correction of precipitating events such as infection, GI bleed, constipation, then dehydration, sedatives, alcohol intoxication, or electrolyte disturbances. Then, main treatment of hepatic encephalopathy. So, for treatment purpose, non-absorbable disaccharide, that is lactulose and the lactitol, are recommended as first-line treatment for hepatic encephalopathy. Lactulose is the laxative which has negligible impact on gut microbiota, composition or function, and likely works through increasing intestinal transit as well as acidification of bowel medium. Subsequently, ammonia production is reduced in the gut and the fecal excretion is increased and ammonia absorption is reduced. Lactulose is the agent most extensively studied in patients with episode of hepatic encephalopathy. A recent concurrent review demonstrated the beneficial effect of non-absorbable disaccharide on hepatic encephalopathy severity, prevention of hepatic encephalopathy mortality, and on serious adverse events such as liver failure, variceal bleeding, serious infection, spontaneous bacterial peritonitis, and hepatorenal syndrome in randomized controlled trial. Lactulose therapy is not without risk, and potential side effects include diarrhea, nausea, bloating. So, diarrhea and vomiting may lead to electrolyte disturbances and even exacerbate hepatic encephalopathy. So, the dosing of lactulose can be started at 15 to 20 ml every 12 hours until two soft stools are passed, followed by titration to 2 to 3 semi-soft stool per day. In randomized controlled trial in hospitalized patient with episodic overt hepatic encephalopathy compared with lactulose therapy, a single dose of polyethylene uh, glycol significantly improved overall grade of hepatic encephalopathy after 24 hours, reduced days to hepatic encephalopathy resolution, and led to shorter length of hospital stay. Now, the next treatment of line is antimicrobial agent. So, rifaximin is the semi-synthetic and non-aminoglycoside which act against the gram-positive, negative, aerobic and anaerobic enteric bacteria. It binds to the beta subunit of bacterial DNA-dependent RNA virus, inhibiting bacterial RNA synthesis. It is administered orally and is minimally absorbed, lowering the risk of bacterial resistance. Rifaximin also has negligible impact on microbial composition, but supposed has beneficial effect on functionality, reducing secondary bile acid production, and its effect on bacterial translocation are controversial. No dose adjustments are necessary in patients with liver dysfunction and renal insufficiency. The most solid evidence for utility of rifaximin is the use of the drug as an add-on to lactulose to prevent recurrence of hepatic encephalopathy. Treatment with the rifaximin has shown to increase the proportion of the patient who recover from hepatic encephalopathy as well as reducing mortality. A combination of lactulose plus rifaximin was more effective than lactulose alone for improvement of hepatic encephalopathy and reduction in the mortality, which was due to decrease in sepsis-related death. Patients who received lactulose plus rifaximin also had shorter hospital stay. However, further trials of rifaximin plus lactulose are needed before this approach can be considered standard of care. So, next line of action is probiotics. Probiotics are the live bacteria that are believed to improve gut dysbiosis and negatively impact the ammonia production. A concurrent systemic review concluded that probiotic treatment may lead to improvement in development of overt hepatic encephalopathy, quality of life, and lower plasma ammonia, but the little effect on the mortality. However, the clinical trials to date are of low quality and therefore the evidence remains unconvincing. Now, the next is branch chain amino acid. A recent concurrent systemic review indicated that branch chain amino acid therapy improved the manifestation of overt hepatic encephalopathy while it had no effect on the mortality. So branch chain amino acids have been documented to promote muscle protein synthesis and improve muscle mass loss. However, adequately powered multicenter clinical trial with appropriate control group are still required. The next line of action is L-ornithine and L-aspartate. A preliminary meta-analysis of randomized control trial comparing LOA-LOA with placebo and no intervention control suggests that intravenous LOA-LOA improve overt hepatic encephalopathy. The efficacy of oral LOA-LOA has been subject of debate as guidelines suggested that oral supplementation with LOA-LOA is not effective. A recent meta-analysis suggests that lower has beneficial effect on hepatic encephalopathy, decompensation, and mortality. But number of clinical trials analyzed was dissimilar in the report, even with one stating that quality of evidence was very. Thus, the potential benefit of lower remains uncertain. Now, the next line of treatment is embolization of portosystemic shunt. In some patients with cirrhosis and hepatic encephalopathy, which are difficult to treat or have recurrent episodes, particularly when the liver is not severely compromised, the possibility of spontaneous large portosystemic shunt should be considered. Although clinical trial data in this patient group are limited, and many case reports and large case series from Europe have suggested that embolizing this shunt can elevate hepatic encephalopathy, particularly in patients with a model for end-stage liver disease score of less than 11. More recently, a single center study suggests that although there was significant improvement in severity of hepatic encephalopathy in the immediate post-embolization period, most patients developed complication of portal hypertension or died during following 12 months. The currently available data suggests that shunt embolization is useful treatment modality for patients with cirrhosis and hepatic encephalopathy, but that it should be considered a bridge to transplantation in most of the cases. Then the next treatment of line is albumin and extracorporeal albumin dialysis. Albumin is multifunctional protein synthesis in the liver. The quality and the quantity of which significantly reduced in patients with cirrhosis. Until recently, the albumin was thought as a plasma volume expander. It is now clear that albumin has many additional functions, including anti-inflammatory properties and ability to bind and clear many toxic substances that accumulate during liver. An early uncontrolled non-randomized study suggested its potential role in the treatment of hepatic encephalopathy, but this was not confirmed in randomized control trial. The combination of lactulose and albumin was, however, more effective than lactulose alone for complete reversal of hepatic encephalopathy. So we will summarize the treatment line for hepatic encephalopathy. So first is always stabilization. So that is airway breathing circulation. So if the patient is in grade 3 or grade 4, admit to the ICU. First, follow general care of management, that is, which direct the treatment of the precipitating factor like infection, volume expansion. Then, if there is gastrointestinal bleed, then control it. Then, if the patient is has a constipation, then make use of laxatives, correct electrolyte disturbance, and correct the nutrition. Then specific therapy or standard therapy includes the use of lactulose, rifaximin, embolization of the large spontaneous portosystemic shunt, and according to the lower availability, use of branch chain amino acid, PEG, L-ornithine, L-aspartate, and albumin and extracorporeal albumin dialysis. Now the prevention of overt hepatic encephalopathy. Now about primary prophylaxis. Two recent clinical trials evaluated the efficacy of lactulose and VSL, a probiotic preparation for primary prophylaxis of overt hepatic encephalopathy compared with no treatment in patients with the cirrhosis. Child 2 class B and C and presence of mild hepatic encephalopathy, that is hepatic encephalopathy causing the abnormality of the electrophysiological test and neurophysiological test without clinically detectable neuroabnormality. Well, these are the predictors of development of overt hepatic encephalopathy. So both trials, though from same centers, have demonstrated that lactulose and the VSL are effective in preventing first episode of overt hepatic encephalopathy. So there is evidence that lactulose treatment reverses the this mild hepatic encephalopathy, which prevents the overt hepatic encephalopathy and improves the health related quality of life in patients with liver cirrhosis. Therefore, although it seems logical to give primary prophylaxis with lactulose in patients with cirrhosis at high risk of overt hepatic encephalopathy, further multicenter clinical trials are needed to confirm this early clinical trial data, considering that lactulose treatment may be difficult to tolerate and is not completely without side effects. Now, the secondary prophylaxis. Patients with cirrhosis who have recovered from episode of hepatic encephalopathy, they are at high risk of developing a recurrent episode of overt hepatic encephalopathy. And lactulose is effective at preventing subsequent episode of overt hepatic encephalopathy in patients with cirrhosis, but there is no effect on hospitalization rate or mortality. So rifaximin is add-on to lactulose is more effective than the lactulose alone in preventing third breakthrough episode of hepatic encephalopathy and in reducing risk of hospitalization involving overt hepatic encephalopathy. Long-term treatment with rifaximin as add-on on lactulose does not increase the rate of adverse event and appear to provide continued reduction in the rate of hepatic encephalopathy related and all-cause hospitalization. So VSL3 is the probiotic preparation has been shown to effectively prevent subsequent episode of overt hepatic encephalopathy and reduce hospitalization. But further appropriately powered multicenter studies are required before it can be recommended for routine use. More recently, in randomized controlled clinical trial, long-term albumin administration to patients with decompensated cirrhosis was associated with reduction in occurrence of most of major complication of cirrhosis as well as in the mortality. Now, the next line of treatment is the emerging therapy. So, first is ornithine phenyl acetate. It is the combination of ornithine and the phenyl acetate was designed to increase the muscle ammonia detoxification via stimulation of enzyme via stimulation of this enzyme. This results in the production of the via stimulation of the glutamine synthase. This results in the production of the glutamine, which is converted to the phenylacetyl glutamine to avoid the glutamine metabolism via glutaminase and ammonia regeneration. In addition, it has been demonstrated that ornithine phenyl acetate also chelates the glycine, another aminogenic amino acid. So this OP significantly lowers the blood ammonia in number of different animal model of liver disease and failure. In preliminary communication, the result of phase 2b study were described, which showed that this OP reduces the ammonia concentrations in patients with overt hepatic encephalopathy in dose-dependent manner, but did not meet its primary endpoint of time to improvement in the hepatic encephalopathy. Now the next is glycerol and the sodium phenyl butyrate. Sodium phenyl butyrate is the treatment of choice for patients with the genetic urea cycle disorder. In small study, it was recently demonstrated to improve neurological outcome in association with lowering blood ammonia in patients with cirrhosis treated in intensive care unit setting. So in randomized double-blind control study, glycerol phenyl butyrate was demonstrated to lower ammonia and significantly reduce the proportion of patients who experience hepatic encephalopathy event as well as reducing hepatic encephalopathy hospitalization. So whether phenyl butyrate will continue to develop as treatment for hepatic encephalopathy is not clear. Now the next line of treatment is fecal microbiota transplantation. Fecal microbiota transplantation from healthy normal has been given to patients with cirrhosis to ameliorate the gut's microbial dysbiosis. So recent secondary result from safety protocol suggests the beneficial effect on cognition in patients with hepatic encephalopathy receiving fecal microbiota transplantation. These encouraging results have been associated with enrichment of supposedly beneficial texts. However, understanding of how and why certain taxa are beneficial remains unknown. Now the preclinical stage, liposome supported peritoneal dialysis. Dialysis fluids supplemented with micrometer size transmembrane pH gradient liposome were developed as detoxification strategy for removal of small ionizable molecules such as ammonia. This liposome-supported peritoneal dialysis was able to sequester ammonia in rat model of cirrhosis, lowering the plasmatic ammonia level and attenuating brain edema compared to conventional peritoneal dialysis. Then engineered bacteria, genetically modified E. coli have been programmed to metabolize ammonia. Orally administered, they have been shown to lower blood ammonia in animal model of liver injury as well as in animal with ornithine transcarbylase deficiency. However, the clinical study in patients with cirrhosis did not meet the endpoint for ammonia reduction. Then activated carbon microsphere, designed to absorb ammonia and the other organic compound in the gut. AST-120 demonstrates the promising results by lowering blood ammonia in animal model of liver disease. However, AST-120 did not meet the primary endpoint in phase 2 clinical study, and this may to some extent related to the trial design and activated carbon microsphere merit further development. Then GABA receptor modulating steroid antagonists. So patients with hepatic encephalopathy have increased GABAergic tone potentiated by neurosteroid, which contribute to their neuroinhibition. A new drug of 3-beta hydroxysteroid conformation is shown to effectively antagonize this mechanism and restore the brain function in rat with experimental hyperammonemia and hepatic encephalopathy, and to counteract the effect of administered neurosteroid in healthy individuals. The drug is presently under clinical investigation and has recently been identified as therapeutic target for hepatic encephalopathy. Now the next is glutamine synthetase replacement. Glutamine is important intermediate in ammonia metabolism, particularly when urea cycle is dysfunctional as it is in the patient with liver disease. The main site for localization of glutamine synthetase is liver and muscle. In ALF and the CLD model, the glutamine synthetase has been shown to be upregulated in muscle knocking out the glutamine synthetase selectively in liver and or muscle resulted in the hyperammonemia. So reconstitution of glutamine synthetase in animal model of hyperammonemia was effective in reducing ammonia level. This data provided the rationale for development of strategy for glutamine synthetase enzyme induction or replacement therapy. Preliminary data from study shows that AM535, which is the recombinant glutamine synthetase, reduced ammonia effectively in animal model of cirrhosis and urea cycle enzyme disorder. Thank you, guys.